Hello, overcomers, and welcome to this episode of Connect Over Coffee. I'm Runsi, the founder of Overcome, and today we are joined by a very special guest, Dr. Matthew Katz. So, Dr. Katz is the medical director of radiation oncology at Lowell General Hospital and a partner in Radiation Oncology Associates. He is the former chair of the communications committee for the American Society for Radiation Oncology and external advisory board member for Mayo Clinic Center for Social Media. Most importantly, Dr. Katz prides himself in being a patient-first community medicine-driven physician who works tirelessly and relentlessly each day to bring world-class excellence and expertise to his patients. So join us for the next 45 minutes to an hour as we chat with Dr. Katz about radiation oncology and ovarian cancer, patient care, and some off-the-beaten-track topics to make this a very unique and interesting coffee hour chat. So I have my coffee. Hope you have yours. And while we get on with this discussion, if you have any questions, please type in the comment sections below and we will get it addressed post the discussion. And as I always say, please share this video far and wide with anyone who may benefit from all these great insights Dr. Katz is about to share with us today. So with that, a huge welcome to you, Dr. Katz, to this episode of Connect Over Coffee. Always an honor to have you with us.
Thank you so much. I really appreciate being able to join you, and I look forward to your questions and seeing what I can learn about the community as well.
Thank you. So I have several questions for you, but since you are an expert at radiation oncology, I'm just going to start with a basic question. So tell us about the role of radiation oncology in ovarian cancer and how has it evolved over time, and in which situations is this used today, and what questions should our overcomers be asking of their healthcare providers when radiation is recommended for our overcomers?
Sure. Those are all excellent questions. I think, the role of radiation is less well-defined now than it used to be. I'm a history major by training. I'll go back to when I was in my residency, which is now about 20 years ago. There had been an interest in using radiation therapy much more in the late 20th century, particularly before chemotherapy had been available. The pattern of spread usually for ovarian cancer is most commonly within the abdomen and pelvis, not in a focal area where radiation sometimes might be aimed. And so the role of radiation was restricted to one of two approaches. One was a use of external radiation as an X-ray treatment with what was called whole abdominal radiation therapy. And that was one approach. An alternative was to actually infuse an installation of a radionuclide called phosphorus-32 that would then try to cover all of the surfaces inside the peritoneal cavity without then giving external radiation. And so both had some activity and some role in treating ovarian cancer, but as cisplatin-based chemotherapy became increasingly used, the use of it began to go away. And so there has been interest in external beam radiation still being used. There was a trial from about 20 years ago reported showing it helps with progression-free survival, but not overall survival, but usually with a higher toxicity rate of about an additional 10% of primarily bowel toxicity. And so there have been some continued clinical trials looking at its use, but really phosphorus is no longer used. And the role of radiation predominantly at this point is less in the setting of post-operative or post-chemotherapy treatment than in the setting of a recurrence or in metastatic disease, where external radiation can be used to focus in one part of the body where it may help with symptoms from the disease.
So in terms of, we know a few of our overcomers are still, even though it is not a, very popular mode of treatment for ovarian cancer, but still some of our patients do take radiation in ovarian cancer. So can you tell us a little bit more as to how these patients are identified as being those who would benefit from this therapy versus the others who may not?
I suspect for the most part, many of the women who are offered radiation therapy in the setting of what we call consolidation treatment in a post-operative setting or to try to improve on the results of chemotherapy are mainly in academic centers.
Mhm.
I am at Lowell General Hospital, but also now practice in New Hampshire. I've been medical director and now have a bigger role in my private practice group. And in the community setting, we don't really see external beam radiation therapy offered. So I do think it's probably more likely being offered by people that specialize in gynecologic radiation oncology and participate in academic tumor boards, whereas cases are presented, there may be selected circumstances where it does make sense. So it's something that I do think, if you look at the National Comprehensive Cancer Network guidelines, they're very comprehensive, but they don't actually have any principles listed for how to use radiation therapy as one of the treatment modalities. And so that may be something as an area of opportunity for helping women with ovarian cancer, is to see, are there areas that are worth at least defining, including where it doesn't work, but at least having input from radiation oncology. Most of what we've done has changed in terms of the technical delivery of the external radiation enough. We may have some impact on toxicity in terms of the side effects, and there may be new ways to use it. But also with molecular medicine moving forward, there may be new ways to use radioactive therapies that are molecularly targeted that might still be a value on clinical trials and could eventually lead to new standards of care.
Yeah,
So I think it still needs to be defined.
and I was actually thinking about clinical trials as we were speaking, that it could be that they are part of clinical trials that, at big academic centers that are part of that ongoing initiative. So that makes sense. So thank you for the clarification. And so
Sure.
your interests, you have such great interests in patient care, which very much aligns with our interests, which is wonderful. And so we love your patient-centric and community-centric approach to care, because through our OVARCare program, one thing we have understood nationwide, that majority of our patients are being treated at community hospitals versus these big academic centers. So, and you have actually written about a successful patient-doctor communication as the key to overcoming. So what guidance would you have for our overcomers who are, perhaps newly diagnosed, or even, through their journey, they're in treatment or even in remission, in how could they establish this and maintain a well-performing and communicative relationship with their physicians and as well as healthcare team?
That's a great question, and it really does apply to anyone who's going through a cancer experience to some degree. I do think it differs in terms of the disease experience based upon your diagnosis and also where you're coming from when you have the diagnosis. But it's still essentially at the core should be something that the people taking care of you as your healthcare professionals should be able to do so in a way that they can give you good information to make an informed decision, and the support to do it, and to include the people that are already there for you for support. And so that involves a lot of active listening on the part of your clinicians, the people taking care of you. That's hard to necessarily advocate for yourself sometimes if you're not feeling well, but that's why I always do find it helpful if you have someone with you to really make sure that they can be there as a second set of ears, and if need be, as an advocate for you, to make sure that things are done in the way that you need. And sometimes that means if you know you're going to be going for a consult, you can sometimes ask if you can get information ahead of time that may be helpful, so you come in a little more prepared if there are things that you're going to be discussing. So for ovarian cancer would not be radiation therapy. But if you have looked online and you know that certain chemotherapy agents are more likely, there may be ways to get information about that from the people in the office, which may also be reassuring to them. Because one of the concerns as a healthcare provider is, with people going on the internet, which can be helpful, the problem also can be, how do you distinguish between information, which could be anything, and actually useful knowledge, which would actually apply to your cancer care? And I think sometimes it's not clear where to get it, but if you talk to your providers ahead of time, that may be helpful as a way to get the information. So you go in with information they think would be helpful for you to have before you arrive.
So I think what you mentioned is quite important is, pre-reading some of your expected conversation with your physician can actually help advance your discussion to a more productive, pattern versus not. So, and also taking someone that you trust with you to the appointment, not just because of the supportive role, but also to actually actively engage in the discussion and decisions and information that you may have missed or may be missing because you're overwhelmed with all the treatment and everything else going on. So thank you for sharing those pearls of wisdom. So big academic centers are excellent, but community medicine is relevant, as I always, say that majority of our overcomers, not just nationwide but worldwide, do get treated at community hospitals. And so, tell us how we can make community medicine or hospitals world class in not only treating the patient but also making it the best choice for patients closer to home. Because I'll tell you, just from a practical standpoint, we have talked to so many of our overcomers that would rather not leave their hometown, rather not leave their family and travel all the way across the country to a big academic center to seek, better care. So how can we bridge that gap and make those community hospitals the standards of excellence that they're seeking elsewhere? Because to me, that is so much more comfortable if you are 10 minutes away from home versus, you're on the plane for 3, 4, 5 hours to get to where you need to be. So please tell
Definitely.
us your thoughts on that.
Yeah, I think that's a great question. I think everyone, when there's so much uncertainty with a new cancer diagnosis, should at least think about the value of getting a second opinion to make sure that they're on the right track and that they feel that the decisions that have been made fit what their needs are at the time that those choices are being made. And having worked, in residency and for 1 year at academic centers before going to the community setting, I have seen the advantages and disadvantages of both. Academic medical centers are fantastic in having a lot of resources available, both in terms of personnel and in terms of, being able to offer clinical trials. The issue does depend upon, distance to travel, the cost of going, where sometimes there's a big cost differential between going to an academic medical center and to somewhere that's local, that's in your hospital network and in your insurance. And when the treatments don't necessarily differ, it is something that part of it is your comfort with where you're getting treated. And some people I have seen really do prefer to be in a place with academic learning and with more people involved, even if they have less immediate contact sometimes with their immediate physician or care team, because there is often, research that their clinicians may do in an academic center. In the community setting, there isn't a research focus typically. It's mostly direct patient care. So the advantage of that is more immediate contact with your doctors. The issue is, are they keeping up on what they need to know? And so I think sometimes that hybrid approach of being able to either get an in-person or increasingly with COVID, second opinions remotely may be of value that may make you feel that the care you're getting locally is the quality and the caliber of what you want. I do think one of the things that we don't have the right answer on the community right now is the right level of support for survivorship programs and for navigators. And I think that's been embraced by academic centers much more. And because often, the bundling and payments are better, they have found a way to make it work, and they've done it to try to improve the quality of care. The question in the community is, how do you explain that to an administrator and make sure that they will then fund it with the correct FTEs for the clinicians to have equal services? So that's an area where some places do it or have figured out ways to do it, but it may or may not be as good. And that's where it depends, I think, on the care team.
So a couple of questions as you were speaking. So we have all read research on large volume versus low volume hospitals and how there is always this direction that you should get treated at large volume centers because of the knowledge and the expertise. And this is just widely published information, right? And so I am assuming when they're saying large volume institutions, they're actually talking about academic institutions versus the community hospitals. But yet, I mean, when you are mentioning the differences, I mean, there are, quite a few positives for being treated at community hospitals. So it is, what I'm trying to say is, for an overcomer who's trying to decide with all this published data out, there, how much of it should be a determining factor, like, I must go to a large volume center versus a low volume center. And also the fact that you talked about second opinions. That's my second question, that what if, and these are all candid conversations, right? So I'm just asking that if this person, let's say, were to take a second opinion from a big academic institution and somehow the treatment recommendations did not match, then in that situation, what is the guidance for the overcomer? Because as it is, it's confusing. So any guidance or light you can shed would be appreciated.
Sure. Yeah. I mean, that's difficult when you go to get a second opinion and it clearly differs from the one that you got. Part of it is if there isn't the knowledge of how to make the right treatment choice. It is hard as a generalist oncologist to keep up on every single disease. And so sometimes you may find that someone has a different opinion when you go to one of these specialized multidisciplinary centers, because they focus exclusively on that disease. So there are advantages for that cognitive expertise. When it comes to the treatment, though, the question then becomes, okay, we've made the expert choice. The other part that comes into it is cost of travel, the financial toxicity for cost of differences between care, and the proximity of your support network. If you're going from Lowell into Boston, it's not a good commute, but you could still be home. You don't have to be moving and going somewhere else to get that care if you wanted to get something locally. But what we do for some patients, depending, is if it is something that the local oncologists are open to it, and we usually are at Lowell and in New Hampshire, is we encourage the second opinions. If it seems like the actual care can be given locally, we're happy to be guided to offer something that can be done if we feel that it's something that the delivery of treatment and the support for the patient would be similar. And then what some people will do is, after the next CT scan, if things are stable, you keep on the same path. But if there's a new question that comes up because there's a concern about a recurrence or complicated side effects, then maybe it's a reason to re-engage the experts in a way, if that fits. There's still some people that really prefer to just stick with the experts, and that's fine too. But it is hard if you feel caught between the two.
Exactly. So thank you for weeding it out a little bit for us. So moving on to my next question, because you also did mention this aspect of social media. So you have a huge following on social media, and you're considered an expert in this space. So as you correctly pointed out, information is freely available, but that does not mean all information is good information. So, and for our overcomers, or for anyone for that matter, who's trying to disseminate all this, the great from the not so great, it can often become very tricky to separate the two, and so from the fact from the fiction. So what guidance would you give to our overcomers in using social media effectively in learning more about their disease and gaining support while balancing the potential challenges of being overexposed, for the lack of a better word, to social media? And in your opinion, what is the best way to use social media while going through cancer?
That's great. I don't know if I can answer that in 10 minutes, let alone 10 hours. It's a really complicated issue. What I would say is there are a couple things with information and the issue of exposure, which I think is important. Number one, exposure to too much information or misinformation that may not help you get the correct information or knowledge. So that's one concern I have. The other concern is exposure to a lot of potentially distressing information that may or may not apply to you. And what I have seen is very great support from finding other people who are in a similar circumstance where you know no one that's going through this and someone that understands you. But then it exposes you to the stress of also watching a lot of other people going through difficult times, and sometimes over amplifies the likelihood of concerns about recurrence or toxicity. They definitely happen, but the people who aren't having those problems are less likely to be online. So it often seems more common than it may be. So that's another exposure to that I think tilts it a little bit in terms of what to expect with treatment and the prognosis or the future of having that disease. And the last part of exposure is when you start engaging on social media, you expose yourself to advertisers and other entities that may track you. And so it does create another digital footprint. And the reality is it's great for sharing information. But as we know from HIPAA, which is the Health Information Portability and Accountability Act, which is supposed to allow you to carry information, but also protect your privacy, that does not go well with digital exposure on social media. So we haven't resolved that. So I tend to usually say go slowly. Don't put too much out there to start, and make sure that you're comfortable with information and where you're getting it from first, that it's from reliable sources. So I would start by sticking to academic. Medical centers, Mayo Clinic is linked to Google search, or has been, so that is a more reliable resource. But don't click on the top of the links on Google searches, because those are structured to get them, the people that pay the most to get your attention, not necessarily who will help you the most.
You mentioned such an important point, because I think somewhere I read in an article that when there is this Facebook's groups, not the pages, but the groups where they are supposed to be private, where people are going in, and these are private Facebook survivor groups where every survivor feels very comfortable being in there because it's a closed group. But I read that the information that these survivors are actually sharing on those groups is all like Facebook can and has access of it. So then that's not very comfortable, because there you are sharing your entire personal medical history, your, not only just your medical history, but your emotional, spiritual, all those kinds of experiences, thinking that it's all safe in that Facebook group, but it isn't actually, is what I read. I mean, is that what you also think, or?
I do. Yeah. So I think, each social media platform has its different way of functioning. And what we've chosen to do with social media is we did not want to pay to have accounts. So what they've essentially done is to make them viable is we are the product, our attention, and the only way to pay for all of the infrastructure and the things that we want on it are by selling our information to someone. And yes, this is relevant to ovarian cancer patients. It was the BRCA Sisterhood, who was a group for previvors and for women who had breast cancer or ovarian cancer, sharing their experiences, that they picked up on this in a closed Facebook group, that their information was potentially being shared. And when they looked into it, even though they kept it private, some information was being shared with third parties.
Yes, and that is the reason why Overcome doesn't have a Facebook group. I mean, we have a page, but this was deliberately done on our end not to have a group, because even though it provides that level of support, but we just don't want to do that on social media because of all the risks and challenges involved, because we care too much about our overcomers, and we would not want to open a forum where they come and they share their information, which now becomes publicly available for Facebook and all the other digital platforms. So thank you for your candid answer to that.
Sure.
So just to summarize, then, what you're saying is, in general, it is okay to be on social media, but to follow credible organizations, credible information, and not to overshare, and also be cautious in terms of joining, thousands of these Facebook groups, and just kind of, also use your own judgment in what is actually relevant versus not. And so you are very active on Twitter. So do you think Twitter is a safer platform, for the lack of a better word?
No, not necessarily. I think, the difference with Twitter is it's supposed to be, for the most part, public, so that people that are sharing have a little bit more sense that the information shared is public,
Yes.
as opposed to the illusion of privacy of a closed Facebook group, which it sounds like, although I'm sure, many overcomers would like to have, because it's a great way to engage. It may not be the best way to share information. So it may mean you can share less, and Twitter has to be more real time. It doesn't seem like it's as easy to engage in, but there are ways to do it. And so there are, for example, Twitter chats that are focusing on communities. One using the hashtag GYNCSM looks collaboratively at women with gynecologic cancers of different types, to look at sort of their joint experiences where there are overlaps in some of the stressors that go with treatment, some of the toxicities, because some of the drugs may be the same. And so it is something that you can do it, but it's a bit more ephemeral. So it has to be the right fit. And I'm not sure it fits most people. But it is a way to get information. And the advantage of the hashtags may be that it filters and curates information to people that are actually engaged in using it. And a lot of oncologists do use some of these disease-specific hashtags like GYN-CSM.
Yeah, and the thing is, it's good to use social media to get information, but when it comes to sharing your own personal, very personal and private information, there has to be some sort of a balance. So especially for people with disease and all those details about those things. So thank you. So I loved your write-up. You wrote a blog on For Whom the Cancer Bell Tolls. So
Yes.
this is particularly interesting because I was talking to an overcomer just a few weeks ago, and she was actually telling me that she did not ring the bell after her chemotherapy was over, because she did not feel that this was celebratory. So tell me what you have found about patient experience or stress levels or anxiety or even distress associated with just this aspect of ringing the bell. It seems like you've done some study and research. So this is fascinating. Tell us more about this.
Sure. So yeah, I've written some blog posts for the American Society of Clinical Oncology on different topics. And there had been a trial in radiation oncology assessing whether or not ringing the bell made a difference in terms of people's sense of quality of life and distress. And they had expected it would be something that would be beneficial, and they found that it might not be, and it might be more distressing when they looked at how people felt, 2 or 3 months later. I can't remember the cutoff. And so it provoked some discussion about it, both because this was a clinical trial, but because there has been some research challenging this being put in place. My other hospital where I do work, Elliott Hospital in Manchester, New Hampshire, has done this for over 25 years, and universally has not had any issues that I've heard about it as a clinician. It's been done more with the therapists, but I think there are these different factors that apply based upon where it's used, what intrinsic meaning you try to give the bell. And then I think it's different in a radiation oncology clinic than it is in a medical oncology clinic. In radiation oncology, everyone who can finish treatment finishes treatment because it has a discrete end. And in medical oncology, for women getting chemotherapy for ovarian cancer, if they get a certain number of cycles, it stops, 6 cycles or whatever it may be for that regimen. And so there's a completion point and there's a potential opportunity to address it. If it's billed as a cancer victory type approach, that can come off badly sometimes, I think. And it can also make women with metastatic ovarian cancer or other malignancies who are there in the waiting area feel like they never get to ring the bell, that they're just there getting chemotherapy regardless, and there's no opportunity to have that moment. And it can make them more distressed. And so that's where a lot of the controversy comes in, is does it actually make it worse for some of the other people, depending upon if it's put, in the lobby or at the nurse's station, as opposed to in a closed room where you can have a quieter recognition of it. And also, what are you using? Are you using a war metaphor saying, you're declaring victory over cancer? Or is it recognizing a milestone for having gotten through a difficult treatment? And I think those kinds of differences are not fully sorted out. And no one has implemented it in the same way. So I think there are a lot of questions still about, does it help or not? And then, who really wants it? Is it the staff, so that they actually feel they've done something good for someone when they've made someone feel sort of sick? Or is it really something that each patient wants to recognize getting through this step? So there are all sorts of dynamics that we just don't understand.
Yeah, but generally from your experience, you have seen so many patients. What is your reflection on this? Do you see more patients actually enjoying this versus not? What do you think?
Well, radiation oncology, like I said, is different because we can offer it to everyone, even if it's someone about to enroll on hospice. They may do one treatment for a bone metastasis to get pain relief. Mm-hmm. And I have people who say, I want to ring the bell. And it's mainly because we mention at the end of treatment, if they want, they can ring a bell, but we don't give a meaning to it. And then they can choose to do it or not. And I think because of that, we don't impose the need to do it. People choose if it has any value, and then the people that do it enjoy it. And those that don't want to just don't do it. So that's where I think, at least in our clinic, I haven't seen any problems with it, but I can see where if it is sold the wrong way, it could be problematic.
What I would do is, I was just thinking that just to be more inclusive, if we could have them ring the bell after each treatment, then anyone can do it instead of waiting for the completion, Yep. So that would be one way to include the others. But you bring up such important points, because others who are probably seated at the place where someone else is ringing the bell, and that person is going through maybe 3, 4, 5 rounds of the same thing. I mean, she's or he's not feeling the same emotions. So it's important to recognize that as well. So, and be inclusive. So thank you for sharing that. So sure. I'm going to talk about pathology for a second, because you again bring this very interesting angle to patient care and bringing the patient closer to the pathologist, because it does not happen. And yet I will tell you that our overcomers, just from firsthand experience, they have so much that they want to know from their results. They want to know what the x-rays are showing or what the pathology reports are showing. I mean, their one and only go-to is the doctor and the healthcare team. So I completely agree with you that the communication, or even answering the questions, or making them feel empowered, would be so much more if we could bring in all these people in the whole, care spectrum and have them involved. So tell me a little bit about this, and where do you see, and how do you see we can change and be more inclusive?
Sure. I think, it's funny that I got involved in this, but it fits with sort of what my interests were, which is number one, empowering people to try to understand the disease better that they're experiencing, and to try to make sure that we take away the unknowns that add to fear and distress. And my background in my medical school training is I did 9 months of working as a pathologist at a resident level, because I didn't have to have clinical background to do it. I was thinking of going into pathology. So I didn't have patient care experience at the time, but I wanted it. So eventually I didn't do it. But I really got to appreciate how much they guide a lot of how we approach cancer care in general. And it is something that often patients do not get a chance to really delve into what's the meaning of this radiology report and this ultrasound or CT scan, or what does this biopsy mean, or the results of my oophorectomy. And sometimes they can sort of understand it, but without a visual sense of what it is, it's hard to wrap your mind around some of it. And so it just so happened, because I was involved in social media, one of the pathologists at my hospital, Lowell General Hospital, Dr. Leisha Joseph, asked me to come talk to the department about pathology or about social media. And she said, do you think I could do this with patients and talk to them about their results? So I said, sure, why not? And so she ran with it. And so I helped her, along with other people at our cancer center, look into developing a program that we kept open for everybody. And at least initially, most of the people we had were breast cancer patients, but it was open to anyone. And as a result of an early study that was done there in around 30 or 35 people that looked promising, a multi-center study was done at multiple places, and they did find that it was helpful for patients to get that information. And I believe with that, they have put to the College of American Pathologists trying to actually code the equivalent of a patient pathologist consult. So it's not to provide information about what to do about the disease, but to better understand it. And so they're still sorting that out, but it is something that may be available increasingly, both in the community setting and in academics. Still new, but there's no reason to think that you shouldn't be able to understand what the disease is. And if your clinician does not have the time to explain it, which in my opinion, he or she should, nonetheless, if you really want to go to a deeper level and see the tumor, you can sit down at a microscope and look at it with the pathologist and have them explain it potentially. There's nothing quite like that for radiology, but that, also I could see it being a potential value.
That would be so wonderful, because I remember in one of our conferences, we had a session. We brought in two speakers, one surgeon and one radiologist. So basically, it was a conversation between the two where they were empowering patients as to how we make a decision based on your radiology reports as to what your treatment path is going to be. So it was a real life. They took examples of how they actually talk to each other, and she was asking questions, then the surgeon was, providing answers. Okay, so this is how we do this. That was one of our most watched and most, highly rated discussions, because this was new and the patients were not used to something like this, and they were like, this was amazing. And we felt so much closer to our disease just knowing how decisions are being made and how the dialogue actually happens. So to your point, it just empowers the patient, even if it doesn't change the direction of the treatment. But it's your body. You would like to know how decisions are being made on your treatment path. So I thought that, it is so important. What you brought about is to involve these people more into the care, spectrum, so that we get in touch with these pathologists or radiologists like directly, so that we can answer, get some of those gray areas answered. So that's wonderful. Thank you.
Yeah. Well, thank you. Yeah. I mean, it is something I do think one of the things that not everyone has to do. You've got enough on your plate already in dealing with a cancer diagnosis that you don't have to always be positive or empowered. Sometimes it's helpful to just be able to take someone's guidance, but you're the one going through the experience, and who in some ways is more expert on your experience than anyone and should be recognized as such. So that is something that's important. It's great to have the resources of some other doctors, but I would like to see, and I've discussed this online, have patients, not called patients. It means you have to be patient. It's related to the term suffering. There's no reason you shouldn't be an experiential oncologist. You're going through the experience. You know this disease for you better than anyone. And you can be part of the care team if you want. If you trust your physicians that you're under too much stress or distress to be actively engaged, that's fine too. You shouldn't feel obligated to, but it should be available to you if you want to.
Absolutely. Such great insights. Thank you, Dr. Katz. So I know in general, I mean, I know that radiation oncology is not big and bright for ovarian cancer, but in general speaking, what have been the greatest advances in radiation oncology in recent years that you would like to share with us?
Sure. I think, the historical data I mentioned already in terms of how we used to do it. I think the interesting trends that are occurring across cancer care where radiation may play a role and may have relevance for ovarian cancer is we've come up with ways to use high doses of radiation to pinpoint specific areas of the disease. And this, in some cases, like lung cancer, can compete then with curative surgery. But there are also cases where increasingly we're finding that if drugs are working, but maybe there's one or two areas where it's no longer responding to a drug that you're tolerating well, there's an idea of what we call oligoprogression. There are a limited number of areas that are progressing. And maybe in those circumstances, we can pinpoint the disease with external radiation and give anywhere from 1 to 5 treatments that may help control that and allow you to stay on the same drug if you're tolerating it well, rather than to say you have to switch to the next drug where it may not work as well or it may be more toxic. So it's not, I think, probably as commonly discussed in this area of gynecologic oncology, but it's being discussed across other areas of oncology on an increasingly regular basis. Less discussed, but also there's a recent trial that I had to look this up because I don't see this, but the idea that we would reverse potentially the way we use radiation in many circumstances. The main purpose of radiation in many cases has been obviously to aim at cancer cells and kill them, or what we call cytotoxic treatment. It may be that as we do more immunotherapy and try to get the immune system to be focusing on targeting cancer cells, that the radiation may be able to be given at a low dose that in some cases may stimulate ovarian cancer cells to show themselves more, not to actually kill them, but to make it more visible to the immune system. So that is something that in a couple studies that have been done in other areas, it has not worked yet, but it may be still a new area that we will find will be an exciting area for development in the future.
Hopefully, because, we were talking to Dr. Jazeri before this, and he was, in one of our episodes, he was saying the same thing that, 5 years ago in endometrial cancer or 10 years ago, immunotherapy wasn't doing well at all, but now there are so many things happening. So we don't know what the future holds, and we certainly hope that immunotherapy holds for ovarian cancer as well, because that would be wonderful if there are more options especially for platinum-resistant patients. So
yes.
So, Dr. Katz, I've asked you a lot of questions. What have I not asked you that you would like to share with us?
I think, the question about, well, we touched on it, but the question I would sort of think about would be, what role should caregivers play in helping people coping with an ovarian cancer diagnosis? And that, again, depends who your support network is. But I do think it is something that it's always surprising to see who steps up to the plate to be there for you. I think the dynamics of families differ. And also with friends, some people are just more comfortable being there for help than others. So I think being able to try to identify those people and who are going to be your allies to advocate for you and to listen to you, if nothing else. And I guess the key thing is listening to what your needs are rather than sort of trying to anticipate them and imposing needs on you. So I think that that's something that I would say would be an important thing, is trying to see who is getting where you are with things and can help you comfortably get through this as best as possible.
Absolutely. And I would say that, caregiving, because I have been a first-hand caregiver to my mom and have seen others around me. My dad was the biggest champion, is the biggest champion still of my mom. But, caregiving can be a balancing act in the sense that, like you said, you have to put the patient first and her or his needs first, because I have this example in my head about this particular person who used to make phone calls every single day, thinking that she's actually doing, this is going to make the patient feel very good, that I'm actually checking in on her every single day. And then she would call and spend at least an hour each day talking to the patient about things that she didn't relate to, or maybe she was too tired to even speak that day, or, but she went on. So thinking that I am doing a service talking to this patient.
Yeah.
So I think, the caregivers need to be a little more in tune with the patient, and, in certain cases, just even ask, to your point, that what is it that you need in terms of the help? I mean, if that means for me to be a silent partner, that's great. If you want me to keep talking around you all the time, that's great. Yeah. But oftentimes in our zeal to be the best caregiver, we forget that, the person who is our focus or focal point, we need to respect his or her opinions or where she is before we show off our over enthusiasm to be a caregiver. Yes. So
yeah, and it's sometimes as simple, I think, for overcomers to be able to say, thank you so much for wanting to support me. I need it, but can you just ask me when you want to help? What can I do to help?
Exactly.
And then I can tell you, so that I can actually make the most of the help you're offering, and it'll help you get through a little bit easier.
Exactly. Thank you so much. So great conversation, Dr. Katz. In closing, I would just ask you, what message of overcoming would you have for our audience and everyone that's listening?
I think it mainly is, the cancer journey is not an easy road, but it is one that does give you choices. It's one, they're not easy choices always, but ones that if you can get the support that you need, may smooth the path some. And your care team should be there to help you with that. And that is our job. And my hope is that that's what you'd be able to find wherever you are.
That's a great message. And before we close, since you are so big on social media, would you like to share your handle so that our overcomers may follow you where you are?
Sure. I don't know that anyone's going to be that interested in what I have to share, but sure. My handle is subatomic doc, because I'm a radiation oncologist, but also, the digital portion is electronic. And so it is something that this is sort of a way to help and interact with people. So that's my handle.
And you are in Twitter or all platforms?
I'm mainly on Twitter. I don't use Facebook for any professional purposes. It's really just Twitter.
Okay, wonderful. Thank you so very much, Dr. Katz. This was a brilliant conversation, and it was very candid, and you brought out many, points of discussion that our overcomers would be interested in listening. So we are grateful to you for your time. Thank you so very much for sharing. And overcomers, hope this was very beneficial for you. As I always say, please share this information with anyone that may benefit from all these great insights Dr. Katz shared with us today globally. And we will be back with the next episode of Connect Over Coffee very soon. Until then, you keep overcoming. Thank you and bye.
Thank you.